Dear ITI colleagues and friends, my name is Lorenzo Mordini. I'm an ITI fellow and I'm the PG program director in periodontology at Tufts University in Boston, USA. I have to say that I'm very proud and excited to be one of the Team USA members for the Young ITI World Series 2023. The title of my presentation today is When Classic Meets Innovation. But before I tell you what I really mean about that, I leave you with a little bit of suspense. And first of all, I would like to thank the ITI leadership team for selecting me as a finalist for this great competition. If we think about classic, we can definitely think of David of Michelangelo, which represent the classic aesthetics, the background, the knowledge, the solid knowledge that we have. But also there's another David that is quite the opposite. And he represents the future, the progression, the innovation, the uncertainty of the future. And if we combine these two together, when classic meets innovation, we may get something like this. A painting combining the two ideas. And why I'm starting with this topic? Because I would like to shift gears and tell you how I apply this concept to dentistry. So let me show you this two clinical cases. This patient definitely requires some bone grafting augmentation to place implants and restore this vertical defect. But also this patient was missing the front teeth and we need a dramatic bone augmentation in order to place implants. And you may think, which kind of materials can we use? And you probably know that there's a lot of them. We can start from biologics, from particulate, from block graft, but also membranes, different kind of membranes. And among these membranes, we have even more to pick. There's a lot of bone grafting, like allograft, alloplast, autogenous graft, but also membranes, resorbable, non-resorbable, and different kinds of them. And I had a lot of questions when I started this project. A lot of questions that I turned into research questions because I wanted to apply the innovation to what we knew about guided bone regeneration. And the core question that I had were which membranes and when I can use it. What is the better bone quality that I can get using different kind of membranes? How much bone can I regenerate and how much volume can be resorbed during this period? So this is why in 2012, when there was not a lot of knowledge about this and a lot of data available, we were able to digitally measure the volume of regenerated ridges with the software that I'll show you in a minute what it is. Very common now, but not very common in 2012. We went back to literatures, as I said, and nothing could provide us some data about digital volume measurement. And this is why in 2018, we were able to give back to literature some data, very interesting data about this topic. The outline today is very straightforward. We'll start from hypothesis, material and methods of what we did. We'll show you some results and we'll finish with some conclusions. The outline is pretty straightforward as well. We'll definitely use like healthy patients that were missing some teeth in the posterior mandible, so they were partially edentulous as a candidate class 3. We had 20 patients divided into groups, two kind of membranes, resorbable and non-resorbable, and the ridges had to be less than 6 millimeters in width. Then what we did, remember this still was digital, now is very popular and very advanced, but back then in 2012 we had some limitations. So this is why we had to take some PVS impressions, pour the cast and scan them with some lab scanners at 0 before surgery, 3 months and 6 months post-operative. And then we went ahead with GBR surgeries. We performed like at least 20 surgeries and we placed implants. The cases were divided between resorbable and non-resorbable membrane with the FDBA as a bone graft. Then we measured the bone volume digitally, as I explained to you before, and also volume measurements. Very interesting histological data. After we subjected the bone cores that we harvested, little carrots, after light and electronic microscope, because we wanted to understand the quality and quantity of bone regenerated in terms of percentage of mineralized tissue. But let's step back a little bit. I just want to show you the step-by-step procedure. This is an anterior mandible, but is exactly what we did in the posterior mandible. So we had patient with less than 6 millimeter width ridges, and then we opened the flap, full thickness flap. We created some decortication at the crestal level, and then we first stabilized the membrane placed our particulate graft mixed, and then we closed again with the membrane, stabilized with pins, primary closure of the flap, and this is what happened at 7 months postoperative. And we could testify that this happened in every single case that we performed. As I told you, test and control. The test was the resorbable membrane. We want to hypothesize that they would perform as equal as non-resorbable membrane, which it was still considered the gold standard for this procedure. This is an example of only 2 cases, resorbable and non-resorbable, for the sake of time. On the left, you can see resorbable membranes, and on the right, non-resorbable membranes. On the left, you can also appreciate this round hole, which was actually harvested, the location of the implant, prosthetically planned, and we use this course for bone histology. And the red is the coloration, just to mark the orientation of the course. As I said, for the sake of time, this is the panel, the list of all surgery that we perform with exactly same procedure, step by step, very meticulous. And these were the results. STL files, we went back to use mesh mixer. Nowadays, very, very popular among clinicians, but back then we had to work with a developer in order to identify how we could measure the bone volume. We superimposed the 3 scans, we trimmed them, and we measure the bone volume. And I explain a little bit more the difference between them. Results. Well, between resorbable and non-resorbable, these were the measurements in cubical millimeters, and we could identify with the statistician that actually there were comparable results in volume. And so that at this point, we focused our attention only on resorbable because it was the test that we wanted to prove. A simplification of one of the cases. In brown, you can see the T0 before bone regeneration, T1 at 3 months, and T2 at 6 months. On the left, the volume gain in cubical millimeters, which may not tell you much, but what we could discover is that between 3 and 6 months, we had a resorption of 5%. And this is very interesting data that was not available in literature. Not a great amount, but also good information for the clinicians. Soft tissue thickness, very similar to what we could find in literature, not much changes. And this could prove that the amount of volume that we scan and then we measure was not soft tissue, was only bone and solid graft regeneration. Now, as I said, we went back to the University of Modena for the histological analysis. We prepare our course, with the lab technician, sectioning, polishing, slicing, coloring, and then use of microscopes. First, the light microscope to identify the qualitative analysis of these bone cores. And this is the result. We could actually find some beautiful imaging, a higher magnification. For example, in this case, in the slice, the presence of a slice of graft embedded in new formed bone with osteocytes. And again, higher magnification, we could identify blood vessels as a red circle, but also live cells, osteoblasts and osteoclasts as circles in red. And now we switch back, we went to the ACM for the quantitative analysis, the amount of mineralized tissue that we could find in this location for implant placement. Another image, similar to the one that I showed you before, the presence of a graft in white in the center, embedded by these little holes that were osteocytes. We subjected these bone cores to this software with slices. We extrapolated the amount of mineralized tissue with ImageA, very popular software, and actually we could calculate that more than 47% mineralization was the mean mineralization of this bone cores. Very satisfying. And let me finish with some conclusions. We could prove that there was 5% of volume resorption between 3 and 6 months, that the mineralization was 47%, very high quantity of grade of mineralization, and actually the resorbable, so the test was equal effective at non-resorbable membrane, the gold standard. You can read the paper in JOMI 2020 with our authors, and then this project was awarded as a finalist of the Zara Fellowship for the AP. And with this, if you may have any question, please reach out on email or social media. Before concluding, I want to wish the best of luck to the participant, and I'm really looking forward to see you in Singapore 2024. Thank you very much.